The longer that SARS-CoV-2 virus is allowed to spread unhindered by a medical response like a vaccine, the more likely it is to mutate. And the concern is that mutations may occur which are resistant to current vaccines. We're a prime example in South Africa, where lineage B1.351, or what's called variant beta, emerged in the Eastern Cape in October 2020. This variant spreads faster than the original virus and more frequently causes serious illness in some people. Now, a few international medical research studies seem to be showing a favorable result against this variant and others when they use a mix and match approach, where a person, for example, receives one jab of AstraZeneca and a second jab of Pfizer. Vaccinology Professor Shabir Mahdi on Friday on BDTV referred to the improved performance of this combination against the variant first detected in South Africa. And all this seems to confirm the view that South Africa may have acted rashly and perhaps negligently by getting rid of our AstraZeneca vaccines. Joining me now to discuss this and more is the SA Health Products Regulatory Authority Board Chairperson, Professor Helen Rees. Thank you for your time this afternoon. Let me ask you, before we got rid, can you fill us in on this research that gives Prof. Mahdi the confidence to go on the record about the efficacy of a combo vaccine?
No, well, I think there's more and more emerging evidence about when you combine two different types of vaccine, and particularly what we call two different platforms. That means vaccines that are based on a different kind of structure and a different way to trigger the immune response. So AstraZeneca and Pfizer is one, but there are many other studies that are now going on that will take a variety of different vaccines and combine them with a different platform to look at the immune response, and then obviously longer term to look at the clinical response as well. And for pretty much all of them, it's looking very encouraging that when you mix and match, you do seem to get a more robust immune response.
So that obviously begs the question, why did we get rid of the AstraZeneca? And I know we didn't know this then, but who made the call?
Well, I think you hit the nail on the head when you said you didn't know it then. And I think, to be fair to everybody, that we're learning all the time. I don't think we've ever had such a steep trajectory of learning in vaccine science ever. So when the AstraZeneca was not continued with, if you recall at the time, we had the emergence of the variant. In the laboratory, when we look at the immune response in the laboratory, where we look at something called neutralizing antibodies, the vaccine didn't seem to be effective, and that the virus seemed to be able to escape from the effect of the vaccine. And then we had one small study that looked at mild to moderate disease, which again seemed to show that mild to moderate disease you weren't protected in mild to moderate disease by the AstraZeneca vaccine. Now, at the time, we didn't have the information about severe disease. We could speculate. We didn't know what it meant to have variants and how serious this would be in terms of vaccine effectiveness. So it was on that basis that that decision was made. And the decision was made to try and get hold of the alternative vaccines that we thought, in the laboratory at least, would be more effective against variants.
Prof, let me get this clear.
It wasn't an irrational decision at the time, but, wisdom of retrospect, it would be nice now to have some of that vaccine as well.
Well, I'm glad that you're admitting that, but let me get this clear. Are you saying that at the time we made the decision to let the AstraZeneca go, we were not confident that it would prevent death? Because I understand completely that many of these vaccines you'll still get infected, but you won't die. That's the most important thing. You won't end up in hospital, you won't overburden the health system, and you won't die. Didn't AstraZeneca, even at that point, have that same benefit?
We didn't know. That was the problem. So what we had was, as I say, the laboratory evidence and this small amount of evidence on failure to protect against mild to moderate disease. We speculated that it might well protect against more severe disease, but we just didn't have the data. And remember, this was very early on in the rollout of any of the vaccines. So that was, at the time, why that decision was made. It was really a cautionary one to say we don't have confidence that in the context of this variant, that this vaccine is going to be effective. So I think we must be very careful as we're right to analyze, you're right to ask these questions, but we must just be a little bit cautious about taking the knowledge we have today and transferring it backwards and saying, oh, we should have done that differently. Because if we didn't have the knowledge then, we didn't have it. We didn't know, for example, what we're now beginning to see, which was your first question, that if we combine two different types of vaccine, that we might in fact get a much more robust response. This is information that's really been emerging in the last couple of months.
But like any good medical scientist, you are prepared to say now, if we had known what we know now, it would have been better to have kept the AstraZeneca. So moving forward, do we say, let's add that to our procurement of vaccines? Do we now go back and say, if there's AstraZeneca available, we should take it?
Well, I think that at the moment, we're looking at a number of other vaccines. So the vaccines that we had initially approved were the AstraZeneca, the Pfizer and the J&J. But we've also got other vaccines which are also in these combination studies with other vaccines. We have Sinovac and the Sputnik vaccine, and those are all under review. Vaccines. What we are going to be able to do is to look at the state-of-the-art information about how best to use them. Is it best to give as prescribed? For example, with AstraZeneca, it was 2 doses. With Pfizer, it's 2 doses of the same vaccine. Or is it now, with the information we've got, better to mix these vaccines up? And that, as I say, there are a number of studies worldwide going on now that are mixing these vaccines up.
So let me ask about the FDA's approval of the J&J vaccine. We were expecting news on Friday. Has that come through?
No, it hasn't. And I just want to really reassure everyone that we are putting as much pressure as SAHPRA as we possibly can on the FDA to say, please, we desperately need this information from you. We cannot generate this information sitting here. We have to have this information about what the FDA has concluded when they've looked at the manufacturing and the quality of the J&J that's come out of this particular manufacturing site. They have committed to giving us the information at the beginning of next week, and we have been in contact with them literally over the weekend, just really underlining how important it is for us to receive this information, because it really is a go, no-go situation, potentially, in terms of how we can access the J&J vaccines here.
Okay, so too many of our eggs in the J&J basket. How quickly can we start getting approval on the Chinese vaccine, the Russian vaccine? How quickly can we get them into our system?
Well, again, that is about the data that we have in front of us. There's been very intense to's and fro's with, particularly with the Sinovac. Sputnik is coming through now as well. But we need to get the information from the applicants. When we get the information that we require from the applicants, we're able to look at that. But in addition, Sinovac has now got an emergency use listing from the World Health Organization. And because we have a relationship with the World Health Organization, and because we now have the same dossier as was submitted to the World Health Organization, we will then be working with the applicants and with the WHO to hear what we need to get from the WHO what their assessment was. And we're able to do that because we have a sharing mechanism with the WHO, and that will accelerate things further.
Final question. We changed our phase 2 plan about vaccinating people with serious comorbidities under 60. Do you know why that is?
I think it was a very pragmatic decision in the first instance by the Department of Health. By going for the over 60s, I think that there were several things. One is that age is probably the biggest predictor of severe disease and death. So that is your highest risk group. Secondly, if you go for over 60s, you're likely to catch a lot of comorbidities, things like hypertension, diabetes. All of these things increase with age. So you're likely to catch a lot of people with comorbidities. And thirdly, as we are learning how to roll this out to the general public, healthcare workers in the first instance, but now over 60s, this is the general public. To do a cutoff on age is probably easier than to try and find everyone who's diabetic. I think that will come. Many people go to diabetic clinics, to specialist clinics for people living with HIV, for hypertensive cardiovascular clinics. So I think that will be certainly something that will come next. But I think for the first cut, the department felt that while they are still learning how we are going to roll this vaccine out to adults, which we've never done before on this scale, that the age cutoff was going to be the easiest indicator for them to be able to identify.
Thank you for your time, SAHPRA chairperson Helen Rees.